N-
Hey, Josh.
Gregg.
How are you?
Okay, how are you?
Pretty good.
I think that
everybody's a little.
everybody should know before I leave for an hour, then come back, and then come back again, what amount of work you and the rest of the team uh, went into this event, and it really it blows my mind that you all, every single one of you, are able to have lives and jobs and still do this, because I can barely remember pants most days, Gregg. So this is amazing.
You don't need pants on StreamYard. So. Right. Getting a little loopy. Thanks, Josh.
Bye.
Hey, everybody. So I'm super excited about our next session. And people will say, why are we talking about Mpox? I just want to give you a quick story, and then I'll invite Joe, Miguel, and Nicole up. In 2022, there was an outbreak of what we called monkeypox back then, and Mpox among men who have sex with men in North America and Europe and Australia and some other places. It's an example of what you don't know can hurt you. Mpox was an endemic disease in West and Central Africa for many decades, but many of us didn't think one iota about it in New York or LA or any of the great cities of North America. But during that outbreak, Annie Ramoyne called me up, who's a researcher at UCLA who's worked with Nicole for many years, and said, what can I do? There's a hand reached out from the world of orthopox viruses to people working on AIDS, because Annie Ramoyne saw a need. And as we try to save AIDS research tonight and over the next few weeks, months, and years, we have to think about saving research in general, because we don't know where the next threat is coming from or the next opportunity is coming from. So I want to invite Nicole, Joe, and Miguel up. And I think Nicole is going to speak first. And then Joe and Miguel are going to do a presentation together. I don't know whether you prefer questions after Nicole's talk, or we can do all questions at the end. It's up to you guys.
We can do questions at the end if you want.
Okay, so why don't we do that? So why don't we go with Nicole's talk? I hope somebody in the back of the house. Oh, there we go. It all works like clockwork. All right, Nicole, take it away.
Awesome. So as Gregg mentioned, really no one spoke much about monkeypox until 2022. So this is something that we've thought about for a lot of years, and certainly, as he mentioned, Andrew Moyne has been working on since 2022 or 2002, and many other researchers even before then. So the first time that we saw a human monkeypox case was in 1970 during the eradication of smallpox. And this is when there was really intensified surveillance during the smallpox eradication era, and every case of a pox-like virus was being sampled and tested. And this is when we saw the first human case. But in fact, we talk a lot about the kind of changing name of monkeypox to Mpox. And actually, historically, the first cases were seen in ropes and monkeys in 1958. And this is how we ended up with monkeypox. Mpox has a number of different diseases that have similar presentation, and so oftentimes it's really hard to differentiate between Mpox and other diseases. Typically you'll see on the hands and palms of feet, and this is the historical characterization, and really up until 2022, when I would talk about Mpox, I was using references from 1970s because there really was no other research to work off of. So thinking about really truly neglected tropical diseases that had no other information. So all of our information on epidemiology of the disease, geographic spread, understanding of how the disease transmission happened on these historical records from the 70s and 80s. And so you'll see that it really so much has changed even in the past 5 years that we've seen Mpox really have a huge shift. And for sure, this was not on my bingo card, to see kind of this huge shift in Mpox. It can look like severe chickenpox. It can look like secondary syphilis. It can look like measles. It has a number of secondary clinical, a number of clinical differentiation. And looking back historically, part of the reason that we think that there was really low cases of Mpox for such a long time was that the smallpox eradication program was really successful, not only in eradicating smallpox, but also providing a long-term immunity against orthopox viruses in general. And so by 2002, 2003, 2004, we started seeing increases in Mpox. And this is a lot of the work that Anne Ramoy, my boss, worked on in the Democratic Republic of Congo, really trying to understand what kind of increases there were. In the 1980s, the WHO ran a surveillance program for Mpox to try and understand if we thought Mpox was going to fill this niche left by smallpox. And at the end, they saw that the R value was less than 1, and that this would likely be a disease that would just kind of have stuttering transmission. And then from 1970s onwards to 2021, we really just saw cases in Western and Central Africa, and this is where we've historically seen the clade 1 and clade 2. Clade 1 being in Central Africa, clade 2 historically being in West Africa. Most of my work has focused on DRC and looking at kind of the changing transmission and surveillance over the past 20 years. And we certainly saw that between 2001 and 2013 and then onwards, there was this kind of expansion, but not a lot of understanding of like why there would be this expansion, just that we see more cases, but not really a lot of discussion for the transmission or understanding, is human to human transmission changing? Additionally, in 2003, there was a small Mpox outbreak in the US that did cause some attention to come back to Mpox. However, it was a transmission from a Gambian rat to prairie dogs in the Midwest US. And so we saw almost entirely animal to human transmission with really limited secondary transmission to humans. So really almost everything that we had coming up to 2022 indicated that Mpox was primarily animal to human, with really limited secondary transmission. And then 2022 happened, and early in 2022, we started seeing kind of this expanded transmission. I'm not really going to go much into this, as I know that Joe and Miguel are going to be speaking a little bit more on their experiences of 2022. However, during this time period, we saw huge increases in cases in kind of all regions, places that had never reported Mpox before. However, one thing that happened in the WHO classification was historically cases were just based on suspected case counts. So the DRC led the suspected case counts for the past 2 decades, and all of a sudden there was almost no cases being reported from Africa. And a lot of this had to do with the fact that the technology just wasn't in place to be able to detect cases the same way that we were seeing them in the US and European regions. So when you look at this graph, you can see in the Africa region during 2022, we were looking at the tens or hundreds of cases versus the thousands of cases that we saw in North America and Europe. And so we did a lot of work to try and figure out how to increase sample collection and everything else. But still at this time point, what we were seeing in DRC was a completely different epidemic. Ours was still really primarily animal to human transmission of the clade 1. And it basically changed entirely our understanding of how this disease could evolve. And we saw that within clade 2, it was predominantly affecting men and specifically MSM populations. And so there was a lot of kind of back work to try and figure out how we could work with researchers who had kind of a wealth of experience and how we could put these two groups together to really try and understand what was happening with this changing epidemic for the Mpox transmission. And we waited and continued following in DRC, and sure enough, we started seeing a new lineage of Mpox clade 1 that basically mimicked almost everything that we had seen going on with the clade 2b globally. And so this was really in the eastern part of the country, places that we had never seen Mpox before. And as they started understanding the epidemiology, we saw huge amounts of indication of human-to-human transmission, especially with sexual contact. And we've continued to see this kind of changing epidemiology and continued circulation. So we're now detecting cross-border cases. However, as everybody is discussing right now, there's just almost no funding for really understanding what actually is going on. So a lot of our teams were working on shoestring budgets to try and figure out how these transmission cycles are happening, what's going on with them, how are they changing. We're still seeing reported Mpox cases in rural settings. So these are the historically endemic regions. But now we're seeing repeated introductions into Kinshasa and other large urban centers that then can lead to additional spread outside of the country. And so now we've started seeing the really sustained human-to-human transmission that we saw not only with clade 2 in 2022, but now we're seeing the same type of transmission within clade 1. So really Mpox is providing kind of a real-time history of kind of watching a virus evolve in a way that we haven't seen before, of understanding kind of how these different clades are branching off and how this transmission is changing depending on what clade we're talking about. And so a lot of this just goes into understanding more that we're starting to see. For example, we talked about the APOBAC3 driven mutations for the clade 1b and understanding that could have been a relation to sustained transmission for human-to-human transmission for clade 2. And then, in fact, we saw the same type of deletion with clade 1. And these events are happening not necessarily at the same time, same location. So understanding how are these events happening in such separate locations really just leads to a lot more questions. We've continued this year to see the rise of Mpox throughout the region. This year, Sierra Leone has had a huge increase in the number of cases. Historically, they've seen in the tens or dozens of cases, and now they're seeing in the thousands of cases. In addition, we're seeing the increase of cross-border transmission and just kind of a continued global spread, not only with the clade 2b, but also with clade 1a and 1b. And really, this is just one emerging disease. But we're continuing to see kind of these repeated zoonotic emergences that are not necessarily unique to Mpox. There's huge amounts of high consequence pathogens. There was just a new Ebola outbreak confirmed in Kasai province of the DRC. And we're starting to see that despite the fact that this is a place where they've had historic Ebola outbreaks, this outbreak is not necessarily related at all genetically to that outbreak, but is related genetically to kind of as a new introduction. So just to call that there's continued emergences of diseases. And really some of the things that we've looked at with Mpox are how to mitigate the spread. So looking for vaccines, and there are effective vaccines. Understanding treatments or options that could help the control. So one of them was tecovirimat, had a huge clinical trial, and at the end of it, a lot of the findings were that tecovirimat maybe did not have a direct impact on improving the resolution, but the standard of care that people received in these areas getting clinical trials really had a positive impact then on their survival. And we continue to see challenges with Mpox case management. These are listed for DRC. However, really they're not unique to DRC. The continued limited national research capacity, disconnect between reporting of suspected cases and confirming healthcare infrastructure, and then just the lack of knowledge and understanding really what Mpox is and what that means for healthcare workers who are in these kind of really rural regions or even urban regions. And really, this is like a future risk of a not if, when, but when. We've seen the spread of not only the clade 2 globally, but we've seen now the spread of clade 1. And really, there's a lot of open research questions. And it's interesting because these are research questions that we've probably posted since 2003, 2004, 2005 that continue to persist, that just haven't been answered. So what is the exact sexual contact transmission? Are there other pox viruses, co-circulation, co-infections? Certainly, there has been a lot of work looking at kind of co-infections with HIV and Mpox and understanding kind of clinical outcomes. How are strengthening of the surveillance systems happening, and how do we better understand a suspected case versus getting them to a confirmed cases? Certainly, the reservoir of Mpox has been a persistent question. And now with vaccines, so there's the Jynneos vaccine, which is a 2-dose vaccine. But there's been a lot of discussion of, is there a place for reintroduction of wide-scale use of ACAM 2000? This is a live virus vaccine that also comes with a lot of risks in a changing population that may have immunocompromised populations. And how do you deal with those changing dynamics that maybe didn't have such a role during the original smallpox eradication? And then we continue to look at the risk factors. And do we see Mpox virus persisting, and how does latent transmission happen, or the possibility of sporadic transmission happen? So I think there's still a lot of unanswered questions, and I really appreciate the chance to have gotten to participate in this. And obviously all of our work is done with a huge number of partners and collaborators. And yeah, thank you.
Thanks, Nicole. That's terrific. We'll take some questions in a second. I can see one already in the chat from Tom Payne. So we have Joe and Miguel who are going to present together now, and then we'll all come back together and have a discussion. So take it away, Joe and Miguel, in whatever order you would like to go.
Miguel is going to run the slides and I will present. So thank you so much. I'm Joe, and I am really happy to be presenting here with Miguel, who I met actually through doing this work, and we were sort of co-conspirators at that time, and we'll present a little bit of our collaborative work at the end. So go ahead, Miguel. I'm going to skip right over the Mpox background, since Nicole gave us such an important one. You can go straight ahead. One of the important things I think Nicole talked about that I'll just reiterate is that Mpox really made this transition from leaps from animals to humans that would an epidemic would die out, to this new epidemic form where we really have sustained worldwide Mpox transmission. Even to this day, the 2022 epidemic, as our work shows, still continues to spread globally. Go ahead. You can skip this as well. Okay, so in 2022, we started, relatively early, April, May 2022, cases of Mpox started popping up first in Europe and then in the United States. Go ahead. Here's, May 2022, WHO announced of the sort of global outbreak at that time. And what we saw in the United States already was that there were sporadic cases showing up in the United States. HIV and COVID advocates, sort of these groups I was a part of at that time, that had been doing work for decades on HIV and for years then on the COVID response, started understanding that this could be a real public health problem if it was, as it looked at the time, spreading largely within queer sexual networks. And if we were clearly missing cases. So at this time, one of the things I'll highlight is that we had cases popping up that epidemiologically did not make sense. So they were not directly linked to travel, nor were they linked to a known case. So what that told us, scientists and clinicians who were tapped into the HIV community at the time, was that we were missing something. There was something happening in the epidemic that was not showing up via diagnostics and normal contact tracing. And really, one of the biggest stories of Mpox is that having an HIV research infrastructure and having an HIV treatment and prevention infrastructure gave us the tools to respond to Mpox when we chose to use those tools. Go ahead, Miguel. So this is an article that I co-wrote with two other longtime HIV advocates and queer scientists, Coletso and James. And we wrote in May in the New York Times that we were clearly missing cases of Mpox, that it was spreading via this, at that time, epidemiologically novel networks, so largely by MSM and queer sexual networks, and that we needed to ramp up testing. This was May, we were in New York, there were cases in New York. We all know that Pride is about to happen. We all know that Pride is a time when people travel, 1 million people travel to New York for June and Pride, and people have sexual and social contact in that time. Mpox was supposed to be a public health slam dunk. All right. So unlike COVID, which was a novel pathogen for which there was no vaccine and no test, Mpox comes around that was discovered in the 70s and has been on the radar of perhaps a too small group of researchers, but had been on the radar as a public health threat for decades. We had tests that had been evaluated properly. Those tests were available at the CDC at least. We had a vaccine that ended up being highly efficacious, as we thought it would be, that had been tested via animal studies and was ready to go for use in the human populations, that was not rolled out until it was too late. We also had a treatment, tecovirimat, that was of unknown actual efficacy in patients, but we knew it was likely to be safe. And it was approved by the FDA animal rule as well. So we had the whole package: tests, vaccines, treatment. And what we saw is that although scientific experts from within the community, right? So we're talking about queer clinicians, queer epidemiologists, queer molecular biologists, were going to the federal government saying, here's the situation. We're clearly missing cases. We need to ramp up testing. We need to get ahead of vaccination. That essentially did not occur. All right, go ahead, Miguel. So this was the big question in the epidemiology. Before June, July of 2022 in the United States, we had severely limited testing. We sort of knew something was happening, that testing was missing, but we didn't know what. And Miguel is going to come back and talk about his work on that question. So what did the community do in this time? Again, you have research experts, clinicians embedded within the community who had their ears to the ground and who could see something was going on. Go ahead, Miguel. So what happened is actually the community responded before the national public health infrastructure did. This is just one piece of data from work that I did here in New York City in a large collaborative group working with mobile vaccination. And what I'm showing you in this bottom graph here is this big gray bar is the period of time when commercial sex venues in New York City voluntarily shut. So we think this is just a marker of people pretty seriously altering their sexual behaviors because they had been hearing or they've heard of Mpox on the news, on social media. They might know someone who has it. And that actually occurs, if you compare that to the orange line, which is the number of vaccines given, well before a threshold of vaccines had been given that would have altered the immunological profile across the community. So really, the epidemic you see in blue is responding to the gray bar of people changing their behaviors, which really was community-led. It was for us, by us. Science, contact tracing is failing, testing isn't doing it. People were going to Canada to get vaccines. It was a pretty bad situation. And I'll just add again, thinking about the connections to HIV, it was not lost on us in May that if we let this thing continue to spread undetected, who would be most impacted? Who was already left behind by the HIV and STI infrastructure? You have huge racial disparities, geographical disparities in terms of rural regions, particularly in the South, bearing an undue burden of undetected HIV. And we knew, and we were arguing that Mpox would find those same pockets of people outside of healthcare, without health insurance, without a queer affirming PCP. We knew that was going to happen. And the unfortunate, one of the big take homes here is that is exactly what ended up happening. Go ahead, Miguel. These were the vans. We had a really good time, giving people shots. We gave 90 doses at a sex party here in New York. That was more than half the party. People wanted it, and we were able to give them healthcare on site, and it was awesome. This is a CDC study from about that same time in August of 2022 that just showed via survey that, more than half the people, or around half people, were very seriously altering their sexual behavior before they could get vaccinated. So this was really a community-led process. Go ahead, Miguel. That's it. That's a picture of me giving vaccines. Not giving. I wasn't giving the vaccine. I was present for the vaccines being given.
Yeah, and so I'll take over here. So like Joe mentioned, one of the big questions is like, who is actually being left behind, which is an important question, not only in terms of like health equity, which Joe really elegantly pointed out, but also with regards to public health. How can we stop this transmission that's going undetected? So it's actually really hard to count that which already isn't counted. But a lot of the work that Joe and I do is really focused on how we can use genomics, so a virus such as DNA or RNA, to really inform infectious disease and investigation. And I always like to shout out that a lot of these methods that we'll be talking about were really originally constructed for HIV. So it's really just showing how HIV research really kind of creates a lot of the backbone for research going forward. So really quickly, how can we do that? So if you look at these 5 gray blobs, they represent 5 individuals that had some infectious disease X. We can sample their virus, sequence them, and then compare the mutations between each individual virus. We can then work backwards in time to create something that looks like this, kind of a family tree, or something we call a phylogeny, where these internal nodes are kind of like the grandparents in a family tree. The really cool thing about viruses is that usually mutation happens at a really similar time scale as transmission. So mutations act almost as a diary of how transmission happens, meaning that these kind of like grandparents in the family tree of the viruses represent ancestral viruses that we never saw, we never sampled, but ultimately gave rise to the viruses we see in the present. So by understanding the genomes of the viruses in the present, we can begin to understand something about those people that we didn't capture in the past. We can then take this tree or this phylogeny and overlay it with key epidemiological information, such as when and where these viruses were collected from. And again, work backwards in time to kind of estimate where and when these kind of ancestors existed using our fancy models. And just really quickly here, you can tell that there's more blue than there is orange, kind of giving the idea that there was a higher prevalence or larger population size of the virus in country B compared to the orange in country A. And that somewhere in the past, somewhere along this transmission chain, there was a jump of the virus that was imported from country B all the way into country A. And really this process of combining genomics with epi, with immunology, is something we call phylodynamics, and that's the backbone of what we'll talk about going forward. So we can use phylogenies to understand how viruses evolve. So you've probably seen a lot of these trees with regards to COVID-19. So here's one with for Mpox, showing the wide diversity of Mpox. Like Nicole mentioned, a lot of talk right now is about clade 1 and what's happening over in the DRC. We'll be focused on what's on this red box, which is clade 2b, which is caused the majority of the cases in the 2022 epidemic around here in the world. So if we focus on the genomes that were collected just in 2022 in areas that were most affected, so in Central, Western, and Southern Europe, as well as North and South America, we can try to understand what was happening under the radar. So if we get this, all these genomes, make a really, really big tree, and then I kind of cut them up so we can highlight the circulation that's happening in each region. So for example, if you just look at the blue box, it represents all the transmission that's happening in North America specifically. And you can see all these little horizontal lines are transmission that's captured by the phylogeny, so captured by information in the genome. And over, I don't know if you can see them, but on the left, you see different color dots. And each color represents where our model is inferring that the virus was introduced from. So if you see a little orange dot over here, it's essentially showing that our model thinks that the virus that led to this huge chain of transmission in North America was introduced from Southern Europe, giving us an idea of how viruses transmit and travel throughout the world. And as you can see, there's a lot of horizontal lines way before these vertical lines show up. And these vertical lines represent public health cases that were captured by public health surveillance. Again, giving rise to the idea that Mpox was circulating in almost every single region studied, even before public health even knew what was happening. It's really hard to protect from that which we cannot see. And a lot of the work that Joe did on the ground with a lot of advocates on the ground really kind of highlight that the importance of doing this work for public health. If we clean up this and just highlight the ones that our model thinks it's most confident in, you can see very clearly that there's just a bunch of dots happening before cases start up. kind of reinforcing this idea that there was a lot of Mpox in 2022 in almost every region studied before public health even knew what was going on, showing how important it is to have really robust surveillance and how important it is to really make sure we're capturing those people that are left behind. When we can use our models and also to understand how important, kind of put numbers on what Joe was talking about. So Joe talked about how important behavioral impacts were on controlling the epidemic. So we can kind of put numbers to that by calculating something that's called RT, or time varying effective reproduction number. It's a fancy epi thing, but really if an RT is above 1, it means an epidemic is growing exponentially. And a lot of public health action is really focused on bringing that RT below 1, where the epidemic is decaying. And if you just look at this blue line here, which is representing the RT based off our models, specifically in North America, you see that if it's above this little dashed line, it's above 1. So you see that RT is pretty much above 1, which means the epidemic is growing before kind of August or September of 2022. And then it drops below that dashed line around that time. And then if you look at this other orange dashed line, which represents the cumulative percentage of high-risk individuals, so people usually that are counted as MSM or are HIV or are living with HIV, it's the cumulative percentage of high-risk individuals that have any sort of vaccine-induced immunity against Mpox. And just kind of showing that the RT, again, the epidemic transmission risk, drops below 1 before even 10% of individuals really have any sort of vaccine-induced immunity against Mpox. Kind of showing this idea and supporting this idea that it wasn't necessarily vaccine campaigns, although the vaccine is very effective. It wasn't necessarily vaccine campaigns that drove the epidemic to crash. It was a lot of, in big part, either infection-induced immunity or behavioral modifications pushed by a lot of really robust queer advocacy. And if we compare them just over here with standard epidemiological models, as highlighted here with the gray dashed line, it assumes it's showing how quickly, how much accumulation of immunity you have to really get under these basic models of epidemiology and infection risk. And the red line shows what our model is showing, is showing that it's dropping a lot quicker than we expected to. Again, just kind of giving more support to the idea that it wasn't necessarily vaccines that were causing this drop. It was more infection-induced immunity as well as behavioral campaigns. And we really show in 2022 just how Mpox was able to disseminate around the world and how much undetected spread really promoted rapid and local transmission in all different areas, and how really it was these behavioral modifications that really curbed spread prior to vaccine campaigns. However, like we mentioned, this is in 2022, we're already in 2025. So kind of the main idea that Joe and I have been working on is how is Mpox being maintained in the US currently, especially given kind of following that idea of given that a lot of attention has been decreased and kind of gone away from Mpox, at least domestically, who are the people being affected and who are we missing? So here I'm just showing the case count specifically in the United States in 2022. I'm just kind of showing it as a proof of concept to show that there was a peak. There was a lot of cases, a lot of people were affected. And you kind of just expect when you see this classic peak in all our EPI classes that it just kind of goes up and kind of drops. But if you just look at 2023 and 24, it just kind of stays. So Mpox doesn't crash out or doesn't come back to be another epidemic. And a big question is, why is it happening? So given that the US is so heterogeneous and each city is kind of like its own little island and its own little microcosm of a lot of things that's happening, we can focus on a specific area to kind of really understand this. So we focused on Los Angeles County, which has a really, really big really large queer population. And as you see here, it follows the same track as the United States. You have a big peak in 22, and then you just kind of have these blips and a low-lying prevalence of Mpox in 23 and 24. We can use, again, our genomics and phylogenomics to really understand what's been happening. So here is just showing that I'm analyzing a lot of the genomes that are collected by the really robust public health surveillance that's happening in Los Angeles County. It's only thanks to a lot of the great work and funding that happens to public health that all this work is really possible. And then we can start doing fancier things like trying to understand what's actually driving the dynamics in Los Angeles County. So in the blue bars in the back, those are actual cases. that were captured by public health, and the purple is just kind of cases that are reproduced by our model that is informed by genomics of the virus. And as you can see, it can capture the cases pretty well, but there's some moments in which it actually diverges, where you see that there's actually a lot more cases that are estimated by our model, but are not captured by public health. Again, giving this idea that by looking at genomics, we can actually start to see that there's a lot of cases that aren't being captured by public health surveillance and that are potentially really driving a lot of spread. We can also use our models to understand where the virus is coming from. So this is a little bit of a complicated figure, and I'll walk you through it. What we do is we look at transmission clusters, so kind of little small outbreaks that are happening in Los Angeles, and we work backwards in time to see when they were introduced into Los Angeles. So every single dot represents an introduction of the virus outside of Los Angeles into Los Angeles that ultimately spread. And then, as you can see, there's a lot of dots that are happening in 2022, showing again that like how big that epidemic was in 2022. But you can continue having these introductions that are happening throughout 23 and 24. The colors of the dots represent how big the ultimate outbreak was. So you can see that a lot of them are just kind of one-off introductions. One person comes in and is infected, one person is infected. But every once in a while, you get an explosion of cases where you're able to infect more than 10 people, really causing this kind of dynamic of maintaining low prevalence. And if you see the yellow is kind of just putting a kind of a rate, or the rate of importation, or how many importation or frequency is coming into Los Angeles over time. And you see that isn't constant, that there's peaks and ebbs and flows as to when the virus is coming into Los Angeles. If you focus mostly, if you look at, and that's described here by this yellow graph. As you can see, from each dot comes out kind of these little tails. And the length of the tail represents how long that transmission or outgoing outbreak is, kind of really showing how long each transmission cluster is lasting. And something I always like to point out is that usually you see kind of a little bit of introductions. You see a really big wave of introductions every once in a while, and the tails kind of last long enough until the next wave of introduction comes, kind of giving this idea that you're having this kind of like stacked wave of introductions and stacked wave of outbreaks that are just kind of meshing together and giving rise to like that low level prevalence that we see in Los Angeles County. We can see this kind of like ebbs and flows a little bit better when we're looking at the number of introductions that are coming in by every month. We see a lot of introductions coming in early summer, most likely due to Pride events. And we're seeing a lot of introductions coming in later in the summer that a lot of our public health folks thinks are due to a lot of queer events that are happening, usually in Fire Island or Providencetown or other places around the US and the world. And then people are coming into Los Angeles back home and then kind of starting the cycle up again. So really using these techniques, we can understand how the virus is really evolving in Los Angeles and how we can use that to really target public health interventions. And kind of like I mentioned, kind of to understand what's really driving this, we are able to take our really big fancy model and put it in an even fancier model, which we call a micro simulation model, which kind of attempts to replicate what is happening in Los Angeles County. So we're able to use our data-driven approach to create kind of a micro simulation or a small like counterfactual of what's happening in Los Angeles County to understand kind of the dynamics flowing into it. We're able to reproduce, so our model, by tinkering with a few knobs, are able to reproduce the cases that are happening in Los Angeles, which you see in the gray bars in the background, and all like the squiggly blue lines are just our model's attempt at capturing the true number of cases that are happening in Los Angeles in 23 and 24. And by kind of poking around and probing all the little knobs and whistles that we have in our model, we're able to understand kind of the mechanisms that are driving the Mpox spread in Los Angeles. So for example, we're able to see that our model, which is informed by all these introductions, has a really hard time capturing the like empirical number, or the true number of cases in Los Angeles, which is highlighted by this dashed gray line. If we just assume that people are not having sex, if we assume that people are having the same amount of sex as they were having once Mpox was spreading in 2022. If we assume then that people are returning to normal sexual behavior, that people are having very similar amount of sex as they were having prior to Mpox, really early on in the summer before Pride happened in 2022, then our model starts saying that, hey, we're able to really capture and recapitulate the number of cases that are actually happening in Los Angeles County, kind of giving us this idea that we need both importation, so a constant source of fresh spark of Mpox into Los Angeles County, together with an increase in sexual behaviors coming back to kind of pre-Mpox epidemic times. And that together is really maintaining a really kind of this low-level constant Mpox dynamic in Los Angeles County. And then we can use our model, which is like calibrated to Los Angeles, to start playing around with it and work with our public health folks to really design interventions that are targeted to specific cities, targeted to specific populations, and really make sure that we're able to take care of those people that as Joe highlighted out, that we're constantly missing and we're not doing a great job of capturing.
Just to end and throw back to questions, as Miguel said, we knew in May 2022 that Mpox, we actually didn't know what co-infection of Mpox and HIV looked like. We were afraid to find out. And when the epidemiology came out at the end of 2022, all of the deaths, every single Mpox death in the United States was in a person with undiagnosed HIV. I believe there was one case with someone with a severe severely compromised immune system due to cancer. But really, it's this combination of a compromised immune system and Mpox infection that is deadly. So, exactly the people who are being left behind domestically in HIV are the people most at risk of severe Mpox and death. The cases are horrific. We don't show any pictures here, but you can go ahead and go to the next slides. This correlates with poorly controlled HIV. So the lower your CD4 count, the worse your Mpox is likely to be. Go ahead. And, we don't understand why, but people with Mpox who are not on antiretroviral treatment basically are not responding when put on antiretroviral treatment. So there's something really horrible about the combination of these two infections, which again means that HIV prevention is preventing severe Mpox, and Mpox surveillance and outreach is an opportunity also to bring people into HIV treatment and care. Thank you. Oh, our thank you slide. Yeah. Thank you, everybody.
Thanks, y'all.
So that was great, Joe, Miguel, and Nicole. I have lots of questions, but there's one that's been lingering in the chat and that's sort of been like pounding at my head over the past 45 minutes by Tom Payne. And I think it speaks to a lot of my fears when I think about Mpox and emerging diseases. Tom Payne writes, what is the current status of global human disease surveillance monitoring emerging in native pathogens? If anyone wants to take a run at that, I think the story of Mpox tells that sort of historically, but there's stuff happening with CDC and NIH right now that might make this question even more worrisome. So Joe, Miguel, or Nicole, anyone who wants to jump in?
That's a Nicole question, I think.
Yeah, I can start. I mean, I would say there has been a lot of attention on kind of improving disease surveillance. And I'd say, for example, the most recent Ebola outbreak that we saw in Kasai Oriental or in Kasai province, there was already a number of cases before we even started hearing that there was a potential outbreak and getting samples. So I would say we're still seeing delayed responses, delayed ability to get samples. I would say once we do have a sample and it's making it to a lab, our diagnostic capabilities have really increased quickly. I mean, from the moment that the lab was able to get the sample from the current Ebola outbreak to when they confirmed the case was in under 24 hours. But it took a few days, weeks to be able to even get to that place. And I think, I mean, obviously I speak from a DRC experience, but over the past year, we've had a number of unknown or the disease X coming up, and before we even get to the place that these are being reported, it's taking weeks of undiagnosed cases understanding what's happening. And I imagine that this is not just individual to DRC, but everywhere. However, like I said, within diagnostics and certainly the ability for doing genetic sequencing and kind of having a quicker response once those samples are getting to the right place has really improved.
I'd like to point out that I think we see this not only just with Mpox, and it all seems that sequencing is very country dependent. I think we saw a lot of lessons from COVID-19, that there were significant disparities in terms of who was sequencing and where the information was coming from. A lot of the reports were coming in from the UK, a lot of them from the US that had probably the most robust sequencing capabilities. But we're really, like, whenever you see the maps of global sequencing, we're missing a lot of information coming in from especially the global South, which usually bears the brunt of a lot of health inequities. So it's hard. I feel like most of all this work ends with, we need more disease surveillance, but it's kind of hard without a unifying body of public health to really kind of wrangle resources together and create some sort of global sequencing kind of consortium. I know some folks are working on like an interdisciplinary pandemics work throughout with the WHO, but a lot of it really seems to be very country dependent, which kind of furthers already existing inequities.
So I'll just do a little bit of editorializing here. We've talked a lot about NIH funded research, but the CDC is the front line for a lot of global infectious disease surveillance, and it's being decimated by budget cuts. And so as you're calling your members of Congress or your local officials, it's not about just supporting NIH research on Mpox and HIV and TB and HCV and all these infectious diseases that threaten us. It's about CDC, which is doing frontline public health research and surveillance. There's another question in the chat from Meredith Green that says, what are some of the common lessons from HIV, COVID, and Mpox that we can apply to future pandemics?
I can pop in on this one because it sort of piggybacks off what you were saying, Gregg, is that we found in COVID-19 and then really acutely in Mpox that, you really need an integrated whole of government response, and you need it before you think you're going to need it, right? Like, we were late on COVID-19. We were late on, we could have, I really believe that if we had vaccinated preemptively, if we had testing scaled up, when advocates, by the way, when community advocates were asking for it in a science-based way, we were saying we are not capturing cases because the epi tells us we're not capturing cases, and therefore we need to scale testing. You have an available test. Let's just get it done. It's freaking PCR. It's like, this is not rocket science. That really showed that until we got a White House office, we really could not get anything done. So you need an integrated whole of government response, and exactly what you said, Gregg, is exactly what you need is what is being taken apart brick by brick by brick. And so everywhere that cuts are happening, between the Peter Marks leaving the FDA, who was not our favorite person in Mpox, was kind of holding up the vaccination, but you could go and argue with him scientifically and maybe change his mind. Even he's gone. Like, oh God, so it's really troubling that the FDA is under attack, CDC is under attack, BARDA, I have no idea what is happening with stockpiles and BARDA, so all of these pieces feel like they're holding up back a lot of pressure right now.
Thanks, Jill. Go ahead, Nicole.
I was going to say also media messaging, how the media's role has played in kind of all of these and the stigma that we have to undo, right? Thinking back to the early stages of the HIV epidemic and the amount of stigma that came out early on that probably stagnated a lot of research or movement that could have happened to have positive behavior changes. We then got to COVID-19 and we ended up with the same thing of kind of how the media was portraying our scientific messages and the doubt and hesitation that it cast on the population that then had to be undone. And then we come into the Mpox epidemic, and there's a discussion of the use of the name of monkeypox versus Mpox, and what populations were affected or historically affected, and then the stigma that went along with that now we're having to backtrack and undo. And we just haven't necessarily learned from these lessons of how the media really kind of impacts kind of all of the research that's going into this, and now how, despite our research coming out, we have to now backtrack and kind of combat any of the misinformation. And so I'd say, how can we better do that in the future pandemics? When the next thing comes out, how do we avoid this certain stigmatization of certain populations? If there is one population that has a higher effect, or how do we stop misinformation or minimize it so that we don't have to start already at a harder place when there's vaccines available, when there's treatments available, when there's information, behavior change, all of these pieces that could have really mitigated any of these kind of outbreaks or pandemics or epidemics.
Go ahead, Miguel.
It's okay. Yeah, I do have to say, like, I really want to highlight what Nicole said, because like starting at the 2022 Mpox epidemic, like I got most of my information from text message chains or Instagram posts from friends. And like, I work in a hospital, I'm an epidemiologist. Like, I can't imagine how difficult it must be for someone who doesn't have access to that health literacy. Additionally, some like really concrete things that are happening, some things we've learned from COVID-19 and from Mpox, are a lot of good research into either metagenomic sequencing in order to make sure that we're doing surveillance in clinics and hospitals in a way that's unbiased and untargeted, so we're able to capture infections before we actually know what's happening. Kind of like Nicole was saying, it takes a lot of time to find that disease X, as well as wastewater sequencing that's happening around the country and around the world that are really trying to find, again, this kind of disease trends that are picking up before we start getting all this disease, before we start getting actual specific testing. And I want to highlight that a lot of this work is actually funded through the CDC grants, like such, for example, through the Pathogen Center Genomics of Excellence, that is given to a lot of public health departments around the US. And that funding has been really cut and kind of really stymied. And even that hasn't been cut, has been showing a lot of delays. So we have a lot of really great research going on and trying to learn from these mistakes, but it's kind of really hard to implement them when kind of a lot of our channels have gone silent.
Great, thanks, Miguel. So I have a question. So when Annie Ramorn reached out during the 22 outbreak about how Mpox researchers could help deal with the pandemic in the US, I don't think we thought about the potential for outbreak among people in sex work and men or sex with men in DRC and other places. And Nicole, you've seen the shifting epidemiology of the disease in DRC, and is anything from the AIDS response sort of informed how you approach sort of these new sort of sexual transmission chains that are appearing over the past couple of years?
Yeah, so I mean, in DRC, because we saw kind of a delayed introduction of the human-to-human transmission, right? Through 2022, 2023, we were still almost entirely dealing with predominantly, or what we thought, animal-to-human transmission of clade 1A. When we started seeing evidence that more urban populations were being affected, populations that had no contact with the forest or any other type of areas that we've historically seen, I think we were able to almost immediately kind of take the experience from the US and Europe and already including the National HIV program, peer educators, different populations pretty immediately. And so for studies that we did, we already had included like the National HIV program. We already included peer educators to be kind of a part of the teams. And so I think pretty immediately, like once we saw that there was a changing transmission and we had kind of the background of what was happening in the rest of the world, I think, being in the DRC, there was some hesitation, but when we started seeing it, there was pretty quick reaction to changing how we were dealing with understanding Mpox transmission.
Great, thanks, Nicole. So we end up in these situations because we ignore the things that are right in front of our noses, right? And Mpox, as Miguel and Joe said, has not gone away in the U.S. We just saw the public health emergency of international concern removed from the current outbreak in DRC and surrounding countries. What do you think is up for the next phase of Mpox domestically and also in DRC and surrounding countries? Because we don't have enough vaccines, or we do have enough vaccines, but they're not getting where they are. We have poor surveillance. What are the next sort of things you see on the horizon and ways we might be better placed to respond to them?
I can lead that off. I think we all have something to say there. I'll say that the trend that Miguel and I found in our work together of these sort of sporadic cases popping up is not going away. I can't imagine that going away. And one thing that I found in talking to people who have had Mpox in 23 and 24 is there's almost more stigma around it now because it's not being talked about as much. Fewer people, there's no attention in the media. Fewer people are going to the media about their experiences with the infection. So it's a pretty lonely experience to have Mpox in 23 and 24. And it's not going away. It's just going to be another STI. But again, to think about this compared to COVID, you can, be asked to self-isolate for 4 or 5, 6 weeks with this infection. So, all those social supports, financial supports for folks who are working, that's an ongoing need. And then you have open questions that are not being researched at all about duration of immunity from both vaccine and previous infection. So, I get people asking me all the time, am I going to need a booster? The answer is not only do we not know, but we're not even studying that question. And so that's a real problem. And at some point, that will become a public health issue again.
Nicole?
Yeah. I think so much about the phrase public health anywhere is public health everywhere. Just like I think, like Joe was mentioning, a lot of our work that we were showing specifically in Los Angeles, that it seems that Mpox domestically these days is really maintained by like introductions coming in. Our work focused on Los Angeles and really like coming into Los Angeles from different places, not just domestically, but also around the world. And kind of this idea that it all kind of feels a little bit like a fire throwing sparks. It's going to keep throwing sparks. It's going to keep catching. We can keep quenching them, but we're always worried that kind of those sparks one day are going to catch and then going to keep exploding back to epidemic proportions. So it's kind of really collaborating with our colleagues in the global south and places that are most affected by Mpox to make sure that we're supporting public health everywhere, because like we were talking about, importations come in, they keep feeding Mpox around the cities, and they keep going. And like Joe was mentioning, kind of like subclinical diagnoses because of vaccines coming up. There's a lot of things we don't know about Mpox, how it looks now, and with stigma, it's kind of getting even harder to study. So just focusing on those people that kept getting left behind, and yeah, it's probably it. Go for it.
Nicole?
Yeah, I mean, we've seen these, like, there's been so much that has changed in the transmission like the dynamic for Mpox. Thinking about the movement from kind of one population of groups that were affected to now a whole other population, but something that has stayed pretty consistent is this kind of stuttering trains, that you do see these kind of continued reintroductions of some form, even at a low level, despite the fact that you're seeing really big changes. And I mean, unfortunately, for us, funding that we've had for Mpox research is dwindled. There's just not a funding environment for really anything, and certainly not neglected diseases, especially now that you mentioned, Joe, it's really kind of an isolating event right now in the US. And so it's not on people's minds. And because it's not on people's minds where there's funding available, there's almost no funding. So we're really back to a place of not being able to answer these questions. And I mean, it's crazy to me to think that in 2013, when I started working with Annie and non-Mpox, we had a list of questions. And here we are in 2025, now that we've had additional new clades, 2 public health emergencies declared by the WHO, and that list of questions is almost exactly the same. And I mean, like the ability for our research agendas to be able to move forward to answer any of these questions, just it really doesn't exist. It comes for a moment and then it's gone before we ever have any positive movement on it.
Great. Well, this was a sobering panel with all 3 of you. But it gives me the opportunity to say, call your members of Congress, tell them to support NIH AIDS research, but also research on emerging and not so emerging pathogens like Mpox. Call your congressman, your senator, and support CDC's ongoing global disease surveillance, because it's the first line of defense between us and pathogens that are emerging around the world.
And Greg, can I just add that all of this was only possible because of HIV research for decades.
Yep.
So HIV research is the foundation that all of this is built on.
Thanks, Joe. Thanks, Joe, Nicole, Miguel. I think there's either going to be that weird music or Josh is coming back, or I don't know what's happening. Hi, Miguel. So we're going on to our